Good afternoon, everybody. So, with Dr. CP's wonderful presentations, now this is a surety that everybody is convinced with the idea that full endoscopy is the way to go. And when it comes to full endoscopy for a lumbar disc herniation or stenosis, probably, yes, we know that endoscopy is the way to go, but the only thing is, in the beginner's mind, that this question is always there, whether I should start with a transforaminal surgery, interlaminar surgery, UBE. So which way, which approach to go? So if you see this kind of stenosis, as we discussed, so this kind of stenosis, yes, it can be dealt with interlaminar ways. Same time, if you are good at transforaminal surgery, you can do the same job by doing bilateral transforaminal endoscopic foraminoplasty. Similarly, if you know the interlaminar surgery, you can do the same job by doing the bilateral lateral recessed decompression by LEULBD or what is called as PSLD. You can do the same job. Only thing is you need to understand whether the lateral recessed stenosis or lateral canal stenosis is which exact site on MRI is causing the compressive pathology and which is causing the symptoms. So you need to understand the MRI, the pathoanatomy on the MRI in a proper manner. The same time, many of the time we see the degenerative cascade doesn't give us herniation as a separate entity, but sometimes we get a stenosis with the herniation, and many of the time we overlook facet orientation. Yes, we understand that upper lumbar herniation or a lower lumbar herniations, many of the time this is a protocol that we follow, that if we go for upper lumbar herniations, we prefer transforaminal, and if it is a lower lumbar, when the interpedicular distance is more at L5S1, we prefer interlaminar surgery. But this facet orientation needs to be considered. So in this FAPID algorithm, we included all those patients which had a herniation and stenosis, but there is a stable grade 1 listhesis maximum if it is, and we excluded all the discogenic pain or a chemical radiculitis or the patients which are unstable low grade listhesis, maybe the scoliosis. So all those things we excluded in our study initially. So after confirming that the herniation or stenosis is fitting into our diagnosis with a proper dermatomal match, and when you know the predominance of symptom is whether on the right side or left side or bilateral, then we can decide our approach exactly based on the location of the symptomatic nerve root compression. So how do we see? We need to see all those cuts which is at the upper discal level, lower discal level, middle of the disc, made with the middle of the vertebral body, so as we don't miss any sequestrated herniation, superiorly or inferiorly migrated, and middle of the pedicle. So if we see all these cuts properly, we come to a proper conclusion that this is the offending pathology which needs to be removed. So if we see the upper discal margin, we see that this exiting nerve root is important to be seen at this cut, and this is either the tip of SAP is causing compression, or there is a superiorly migrated herniation, or it may be the extraforaminal herniation which is causing compression. Similarly, if we see the middle of the disc, the compressive pathology is more or less is causing the problem with the traversing nerve root, and then you need to see whether the paradiscal herniation, osteophyte, or the flavum is causing the symptoms. And when we are seeing the lower discal margin, you need to see that non-articular part of SAP which needs to be removed. So are you able to do the same job with the transforaminal axis or the interlaminar axis? So by and large, as per the accessibility, we see the transforaminal surgery can do the job here around the traversing nerve root. Same time, the extended part can be done when you can go across the midline on the opposite side, underneath the traversing nerve root on the other side, and you can deal with the ipsilateral exiting nerve root. But if you see the accessibility of the LEULBD procedure, that is PSLD, that is traversing nerve root decompression can be done, and then if you just tilt the scope, you can go across, that is over the top decompression. So knowing this accessibility, this algorithm comes into the picture that this is a facet inclination, anterior compression, that is the discal pathology, posterior compression, that is the flavum pathology. And if we see the herniation, it can be dorsal migration, inferior migration, or superior migration. So if you know that I need to see all these parameters when I am selecting my approach, master's eyes can definitely see the single view, and they can decide, yes, I would probably prefer interlaminar or transforaminal. But for the beginner, you need to see all this step-by-step algorithm. And we have divided this facet angle based on the 0 to 25 angle. We prefer transforaminal. So we give 1 score to the transforaminal. If it is 26 to 45, we give transforaminal is preferred over interlaminar. So we give 1 point to transforaminal and 0.5 to interlaminar. And similarly, if it is going more coronally, we go more towards interlaminar. So you select the approach which needs minimal bone resection for the adequate decompression of the nerve root without destabilizing the facet joint. And the approach should have minimum 20-degree angle with the inclination. Now if we come to the anterior or posterior compression, so probably we all know that central, paracentral, foraminal and extraforaminal is A1 to A4. But when we talk about the posterior element, that is the central flavum, paracentral flavum or the SAP in the lateral recess, and P3 and P4 is the component we have divided based on if the upper foramen is getting compressed and that is causing exiting nerve root compression, then it is P4, and if it is lower foramen, then it is P3. Similarly, when we talk about anterior compression, it doesn't come as a single separate entity of A1 or A2. It comes as a combination of A1, A2. It can come as a A2, A3. It can come as a A3 or A4. Now posterior component also, you need to know whether there is a central canal stenosis or whether there is a only lateral recess stenosis or there is a facet cyst or there is a only foraminal compression. And same time, if the SAP is hinging on to the exiting nerve root, it can cause a SAP syndrome or it can cause a isolated exiting nerve root compression, that is the P4 component. So if we know all these components and their extent of migration, then we can plan the surgical procedure better. Same time, when the herniation is dorsally migrated, why we are giving importance to this dorsal migration? Because this line decides whether will you be able to go into the spinal canal dorsal to this line, because transforaminally if you access beyond this line, it becomes difficult and you are violating the facet joint itself. So this is called as dorsal near, when this line is not being touched by the herniation. If this line is being touched or crossed, then it is far, and if it is hard, I'll just take 1 minute. So after having this migration and extent, you know that these are the extent of herniation, and you get overall sequence, and we get this extensive table, but this table we have placed in a software, and you just need to select that the angle or anterior pathology, posterior pathology on the software, and this is the calculator. If you just you want to try this, probably this is the calculator which tells us if the gap between transforaminal and interlaminar score is 0 to 0.5, it is surgeon's choice or a preference. If it is 1 or beyond, then approach should be given to the greater score 1. So the L45 central herniation, if you see, this is the classification. If you do the transforaminal surgery, you get the result. Similarly, if this is the case where there is a lateral recess stenosis and this is the score, where you get the scoring based on the FAPID algorithm, and you can do the interlaminar procedure and you are done with the procedure. So in conclusion, the new surgical classification of a causative compressive element needing a decompression gives a simpler universal nomenclature, and the classification guides to the best available full endoscopic approach for the given pathology. Thank you so much for your patience.